So now we have some very fun guests. We are going to have a wound care panel. So I would first like to welcome Sandra Elke to the podium. Sandra, I think she's coming, I see her. Sandra is a nurse practitioner, RN. She is certified in dermatology and wound care, and she has been the lead in organizing this panel, so thank you very much. I would also like to welcome Kim Hazelbaker. She's an RN too. She has a Bachelor of Science in Nursing and is a certified pediatric nurse. Come on up, Sandra. Here comes Kim. I would also like to welcome Carol Schober-Flores. She is an RN. She has a Bachelor of Science in Nursing and is a certified wound specialist. Here she comes. Lisa Taylor. Lisa is an RN and a wound care nurse. I'd also like to welcome Jean Whalen. She's an RN3 with a Bachelor of Science in Nursing and a certified pediatric nurse. Thank you, ladies, for joining us. We're very excited about your panel. So please, everybody, give a round of applause to our wound care panel.
Well, thank you so much for being here, and thank you for inviting us to be here and talk to you about wound care. So in front of you, you have probably 100 years cumulative experience working with patients with epidermolysis bullosa. And the format we chose was an opportunity for us to discuss some of the situations that we encounter day to day in caring with children in inpatient, outpatient settings. So we have many topics that we've been thinking about and we're going to share with you. We also welcome your questions and would love to address them as best as we could. So this morning I got to have breakfast with two of these ladies, and yesterday I had coffee with two of these ladies. So we we're new friends. And we all have the same mindset. We have a passion for making life better for kids with epidermolysis bullosa. And one of the things we were discussing this morning was how do we manage IVs? So if your child has to come to the hospital and requires IV therapy, how do we manage that dressing? So who would like to start sharing some of the things we were talking about? Jean, go ahead.
Many of you who come to Cincinnati Children's know that, I'm short, sorry. Know that it's been a process to work through with our vascular access team, and started several years ago with collaboration with our colleagues at Denver, who sort of started the initiation of the creation of the dressing we use. Our big emphasis is to put a layer on the skin to be the skin. So we always start with with a silicone-based contact layer that could simulate the skin. So that goes down first, and then whatever dressing is necessary can be applied over that contact layer. So as long as the nothing adhesive is on the skin, you can use products that have adhesive as long as they're going on that contact layer. There's also generally a silver or antibacterial patch product that is applied right at the insertion site, and then generally a roll gauze of some sort to go over to secure. And we talked a little bit about how that skin is cleansed, and our vascular access team has a protocol for how they cleanse these sites, and then they are also experienced enough that if that child's skin has breakdown or isn't going to tolerate the routine cleansing, they'll alter that process as needed. And it's not just used in our institution for EB, but we tend to term it our fragile skin dressing. So patients with other, maybe the hematology oncology population, other patients that have fragile skin have benefited from this dressing as well.
Jean, thank you for sharing that experience. I'd like to ask our other panelists from California, Colorado, if you have input as well and some experience you'd like to share.
Yeah, I'd like to. My name is Lisa Taylor. I'm from Palo Alto, California, and it's a pleasure to be on this panel and to be here with the families that we work with. I agree with Jean. I know we use that type of method for doing peripherally inserted IVs or central catheters, and there's another for like if your child was going to have an iron infusion or a blood infusion, it was just going to be for like a day or two. I try to keep things really simple because people don't always have access. You might not be at a hospital that has access to advanced wound care supplies, but you are going to have access to things like Vaseline gauze, which is very basic. It's been around a long time. It's not expensive, and it's something that hospitals are going to have access to. And if you have Vaseline gauze and like conform gauze, you can secure an IV site. You can take like a half-inch strip of Vaseline gauze. You can add some extra Vaseline or other ointment to it to make it a little more tacky and sticky. And then you can place that, well, first of all, let me back up a little bit. We don't like to use tourniquets at our facility. We always recommend using a manual tourniquet. What happens with the tourniquet is it's where it can stretch and cause friction on the skin, even if you have a dressing or gauze placed on the extremity. So we like to use 2 people at least, one person to sort of be the manual tourniquet so that you're just, their job is just to create a little bit of pressure on the arm so that the veins will fill with blood, and the other person to insert the IV. And then when you have the IV in place, you can take those strips, those half-inch strips of Vaseline, they might be 3 or 4 inches long, and place it under the hub of the IV, and then wrap it it's called a chevron fashion, and then you can add some more layers of Vaseline on top of that, and then wrap it with gauze, and you can get it fairly secure that way, and you can use tape on top of the gauze, of course. So that's works well for IVs that aren't going to be left in for very long.
Thank you for that. It's so appreciated to know the high tech. We have a plethora of products in wound care, some very, very specialized, some very expensive, some very amazing products out there. But if you don't have those, it's so appreciative to know what are some of the basic ways to secure an IV. So thank you for that. Any other thoughts?
Well, my name's Carol Schober-Flores, and I work over at the Children's Hospital, Colorado, and we do tend to use the silicone products. We actually have an EB center there, so we make sure we have the products available for these kids when they do get hospitalized. So we also use this silicone patch where we can secure tape on it without securing it on their skin. We do a silver disc, particularly for central lines, to prevent infection. And then we also do prep the area with a surgical prep, but we always rinse it with saline to make sure that they don't get any irritants reactions from that particular prep. We do use tourniquets, or we do manual, similar to what Lisa does. But if we do use a tourniquet, we make sure that it's applied over a good bandage that has foam padding so that it doesn't cause trauma when we release that tourniquet.
And we don't want to forget you. Thoughts?
I think that one thing we do when our patients go home, if we anticipate that they might have to have an IV at their local hospital, is make sure that they have some techniques like Elisa was speaking about, or some other products that they are sent home with that they can talk with their providers about using when they have to present to their local hospital.
So we've talked about IV securement in the hospital and care for that. You know, when we meet a new family, a new baby with who has epidermolysis bullosa, we have to sort of look at the basics. And parents will ask things like, how do you give a bath? So I would love your input on something very practical that you're doing at home every day. How do you give that new baby a bath and avoid discomfort and preventing infection and more pain? So, Carol?
I actually have quite a few bathing tips. Bathing is very important for individuals diagnosed with EB. These kids tend to have problems with high bacterial bioburdens. They have biofilms, they can get infections, and so bathing is a very important part of their daily care that needs to begin early on. So I think it's important to establish a routine early on. We do recommend that our kids actually get submerged into a tub of water 3 times a week, and you want to gently cleanse the area with just very gently clean off the drainage off the skin, or if there's crusts. I'm kind of known as a Vaseline queen. I use a lot of Vaseline to loosen crusts, but it is important to try to remove those if you can during bath time. I think you also need to be very organized and get all your supplies out before you actually start the bath. If you have patterns, cut those patterns out. Pre-medicate your kids if they do require pre-medication an hour before bath time so that that medicine has a chance to take effect. And then adding pool salt to the bath water has made a huge difference for our kids as far as decreasing their pain upon submersion.
Carol, can you tell us more about pool salts? Where do you get those? And what exactly are pool salts?
So pool salt you can get at any supply shop that sells pool supplies. You can get it at Walmart. Usually it's a 40-pound bag and it costs $10. We usually recommend 1 to 2 pounds in the bath water or a couple cups, and you can always add more if it does sting when they get submerged in the water. But basically what it does is it makes the water isotonic so that when they do submerge, it does not cause them discomfort. And like I said, that has made a huge difference for our kids as far as cleansing their skin. And I think probably my biggest pearl for families is the importance of bathing their skin because, as I mentioned, they have a lot of problems with chronic non-healing wounds, and the better you take care of their skin, the better those wounds will heal, the fewer the bacterial complications. My big pearl is that early on you need to establish a pattern for them so that they do understand that it is important to cleanse their skin.
Thank you, Carol. Does anyone else have tips? Any tips to pad the bathtub, temperature, other pearls, vinegar baths, bleach baths?
We'll often use, we work in conjunction with the doctors on their recommendations, and we'll use bleach baths, recommend bleach baths, which has been used for a long time for treating atopic dermatitis and for decreasing bioburdens on the skin. Changes the pH a little bit of the bath water, and it can be very beneficial. And it's you can make it. It's not expensive, and you can just make it yourself. It's the formula is 2 teaspoons per gallon of water. If it's it comes out to about a 1/4 cup if it's a half a tub, and it's about a half a cup if it's a 1/4 of a cup. If it's a full bath, you use a cup of bleach in there. And it just makes it sort of like you have to think of it as a pool. It's chlorination. It's very similar chemically to chlorination in a pool.
I definitely have been, working with the bleach baths, and the parents will say they're very concerned because bleach can burn and that, bleach is irritating. And I have used the same analogy. You're just making their bathtub into a swimming pool. And most of us have city water, so we're drinking bleach every day. So that's one way that I'm assuring to parents that a bleach bath is beneficial and not so scary and toxic. Other thoughts?
I think for bleach, especially for myself, when I have very sensitive skin also, is rinsing well afterwards, because I know itching is a problem for almost everybody with EB. And when I get out of the pool, I itch, so I always try to educate that you need to rinse well after the bleach to prevent that itching. Some other things, I agree so much with Carol that bathing is so important, but there may come times where getting in a tub is difficult, and being able to work with therapists or whatever you might need to do to have adaptations to your tub, to have railings put in, shower chairs, handheld showers, even if you can't submerge, but being able to get the water on your skin and to be able to cleanse the drainage off and loosen up the crusts and what have you, I think is very important, you know, from the beginnings to whatever age you are today, is to be able to find a way to keep bathing.
Thank you for that, Kim. Other thoughts on bathing? Has anyone worked with the vinegar baths? A little bit. And you know, the reason we'll use like bleach is because that can decrease the body's normal bacterial colonization of Staph aureus bacteria. And when we use vinegar, that can work with the bacteria called Pseudomonas, which is just everywhere and on our skin. So using the vinegar, this is all done with intentions for specific purposes.
Our families often they have all their recipes, and so people will mix it up a little bit, and we encourage that, or they'll call and say, you know, it has the scent of Pseudomonas, and so then perhaps just a vinegar soak on a few areas, but still there's bleach in the tub or salt in the tub. So having all those recipes and kind of all those options lined up, we think is helpful and maybe a little empowering to families to feel like they have some options for treating different things. The only other thing I'd like to add is on the bathing of infants, which, you know, we wholeheartedly agree with everything, that importance of starting early. We also recognize that this little baby who their disease is a surprise for the most part, and then that first bath is often, it's a little scary anyway, and so we try to offer a few options for, everybody's always worried about kind of the cricket leg rub of a newborn baby, and they get totally undressed and get in that baby tub and then just shear themselves. So we try to talk about you know, a foam in the tub or something that can come up in between the legs, that could even be lubricated a little bit to try to keep those legs off each other while you're doing that bath. And then getting those dressings back on without further damage. But as everybody has said, emphasizing learning that a bath is part of the important routine early on is pretty critical.
Jean, you mentioned the smell of Pseudomonas. How many of you parents can say, yes, I know the smell of Pseudomonas? Okay, all right. Would one of you like to describe the smell of Pseudomonas for families who haven't identified that yet, or any of our panelists?
Well, I think it's really difficult to describe the smell, but once you have smelled it, you recognize it right off the bat. And we do use vinegar soaks also at the Children's Hospital for those gram-negative organisms, but we don't tend to use vinegar soaks so much to prevent infections. We use them once we suspect it's infected. And then our recommended dilution is 1 part vinegar to 40 parts water, and if it does sting, you can dilute it down even more. But I do think that the vinegar soaks are very helpful for those Pseudomonas infections. Bleach baths are broadly antimicrobial, so it works for all types of organisms, plus it has anti-inflammatory effects. So, I mean, you can't go wrong using a bleach bath, but definitely once you have recognized a Pseudomonas infection, you recognize that smell. And that's when I think the vinegar soaks are very helpful.
Thanks, Carol. You know, Jean, you mentioned using foam in the bathtub. Now, does anyone else use foam in the bathtub, or do you have closed cell foam or open cell foam, or how do you prevent that foam, you know, from becoming colonized with bacteria? Any thoughts?
Well, I think definitely taking a bath for an infant is the most challenging because infants cry, they kick, they thrash, and so we really try to encourage a team effort with the parents, or if they have another family member, when it's time to give a bath, they really need to have time to do it and have a partner help you do it because, again, infants don't like being bathed, they don't like being messed with, and they cry and they kick and they thrash. And one person can kind of be the person to help out so that that infant doesn't injure herself or himself. Also, keeping the bandages intact when you submerge them in the water is helpful so that their skin kind of gets used to that water so it doesn't sting quite so much, and then remove it while they're in the bath, I think is helpful.
I think another thing is bathtub maintenance, like you were talking about, especially when you're older, not so much with infants, but if you do use a pad in the tub that you're sitting on or laying on, you know, you have to change that out. You have to clean it. If you have a jetted tub, you really need to clean it frequently based on the manufacturer's recommendations, you know, to get those little jets clean. Sometimes, you know, if you have like a piece of fleece that you're using, change it out, wash it with hot water. We've even had recommended for some of our patients who have handheld showers and other showers to take the shower heads off, soak them in bleach weekly, and clean them. So I think, you know, maintenance of the tub is very important also.
So we've gotten the kids bathed, and they are ready for dressings, and we know that can cause pain. So in Minnesota, at Children's Hospital, I've had the opportunity to work with our pain team, and we've made an order set to help prevent pain. And one thing we use to prevent pain in babies, which is something my grandmother Helen told me to use for babies, she said use sugar water. And so we actually have a sugar water product. It's manufactured, it comes in little purple ampules, so we'll give a couple drops of sugar when we're doing dressing changes and bathing. So what do you have and thoughts do you have to share for pain control?
I know our NICU uses those ampules of sugar water.
Can you believe it? My grandma was right.
We also have a sugar nipple that are passing that the babies can suck on. And I think that pain control is very variable, whether some families really just want to use that sugar nipple and nothing else. Other patients are taking a variety of pain medications prior. It's very individualized. So you try to work with the family, watch the baby, see those reactions. And the same with the older children. The older kids can at least tell us what hurts and what doesn't, and what works and what doesn't. We have, you know, we've had patients that say it really doesn't make a difference, I just don't want to take it. And so they just tough it through and be done.
One thing with dressing changes and pain control I have found is just keeping that baby warm enough. And so we'll pull warm blankets. We have warm blankets that we can pull out of the warmer. And babies are going to cry because they're cold, of course. So we have used some warm blankets. I had one little fella, we just knew the routine. He needed a blanket under him, he needed one over his head, and he needed one to put over his body when we were doing his bathing and dressing changes. So thinking just about being a baby and wanting to be warm and comfortable. And then, of course, controlling your pain medicines, making your bath water a comfortable temperature for the baby, and having everything ready. So you're going to do your bath, and your dressings are then ready to apply. And also working with the timing. When is your baby more of a happy baby? When they're fed, before a nap, after a nap, finding those times during the baby's day or your child's day? When are they going to tolerate a bath or dressing care has definitely been helpful. Other thoughts?
Well, the other thing too is that if they do have acute pain, you do need to address that acute pain because it may be indicative of an infection or other medical problems. So definitely if it's something new and different than what they normally complain of, it's something that does need to be looked at. But we use the same thing. We use the sugar water. We use a lot of distraction techniques, pre-medicate, pool salt. I think we also address itching, and I think with itching, I think if you give those antihistamine type medications on a regular basis rather than on an as-needed basis, these kids do a little bit better with itching. But we also address issues like anxiety and pain as well. So, and we have a whole team that works with each family with that.
And thoughts, Kim?
I agree. I think we focus on a team approach to address all those same sorts of issues, not only when they're in the hospital, but when they're at home. And our team tries to identify a provider, a local provider that can then take the plan and then move it forward and have a contact person back with us if changes are made or there's questions or somebody doesn't feel comfortable about something. But I think Jean's point is very important, that it is so variable from patient to patient and age, and then anxiety, like Carol mentioned, plays into the spectrum of bathing and dressing changes, not just pain and itching.
And also with infants, they may cry because they're cold, and it's not because they are in pain. They may cry because they don't like being messed with. I mean, infants cry for a variety of different reasons, and it's not always because it's pain related. So, again, it's something you need to keep in mind that, infants just don't like being bathed, and they may cry, and it doesn't mean that they're necessarily in pain.
So we're sort of moving through hospital care, managing IVs, bathing the kids. Okay, so we have our child bathed. The next step, do we do diapers or do we do dressings next? How do you manage that? Oh, yes, ma'am.
How, in the work that you do with teams, in terms of working and often, when you go through this process, the children respond to the parents and this anxiety and anguish. They handle this, and what do you do to help parents to have kind of, this is really control over their own reactions and feelings to some of the environment, they're felt for a while. And also the book music. I mean, what are the things that are maybe less medically technical, but equally as important in keeping fresh and what do you think?
Okay, so, and tell me if I've got your question correct. So, are you a mom of a patient? Okay, so she is asking, how do we help as a team help the parents to deal with their anxieties, because we know babies are little sponges and they absorb our anxieties. So how do we help the parents calm their anxieties so they can then care for their babies? That's an excellent, excellent question. And I'll go ahead and start. I recently had opportunity to work through that with a baby newly diagnosed, and the parents at first were more tentative in watching. So I definitely work with the parents on the level they're comfortable with and ask, do you want to watch? Do you want to help put dressings on? What works for you? So definitely a lot of dialogue, asking parents what they would like to do. So in this particular case, I had a dad who was very, very anxious, and he was just hovering. And working with him, I asked, what would you like to do? And he said, I want to help. So I started with hand washing. Step one, you're going to wash your hands. So you prevent infection. And giving him that bit of control and letting him know the importance of washing his hands was empowering to him. So the more information I gave to him based on his needs, decreased his anxiety and built his confidence. What I tell to my families and my patients is, eventually you're going to tell me I'm doing it wrong, you're going to tell me you do it better, and you're going to tell me you don't need me. And the parents are like, oh no, Sandra, I will always need you. And I'm like, no, there will come a time. And it might take 2 weeks, it might take 6 weeks, but my parents, they do get there where they say, oh no, Sandra, you cut it too wide. Cut that strip narrower. No, we always do the right foot first. And then we'll say, and I've worked with, as we all have, patients from all over the world, and I was just so touched the day this father said to me, Sandra, I no longer need you. And that's our goal, is to be supportive. We don't want you to have to depend on us. We want to be there to support you and build your confidence. And I'm finding, working with parents over the 12 years I've worked in dermatology and wound care, that my parents get there, and my parents do teach the nurses and become confident. But again, we listen to their needs. And we also, as these other team members were mentioning, we use distraction, which might be a Barbie movie. It might be Cars movie. There might be 20 minutes of a segment, a video or a movie that distracts a child. It might be those little hand game things kids play. And now it's those really, really smartphones that can do a lot of distraction. I sing to the kids at times. They really don't care, what I sing. I can sing happy birthday. Some of the nurses have told me, Sandra, don't, quit your day job. But, those sorts of things, just being a mom or a dad, we sing lullabies to kids. We sing happy birthdays to them. We talk to them. And definitely the story about this gentleman I just described, who was very, very anxious but very, very caring, he was magical with that baby, because that baby knew her daddy's voice. So I'm doing the cares, the nurse is doing the cares. We look so professional, so competent, and we're using all the techniques we have in our facility to make that baby comfortable. Daddy walks over and talks to her, and the numbers on the monitor improve. So parents have their own bit of parenting magic. The interesting thing about this family was, Dad was absolutely magical. His voice was magical with this baby. When Mom came, he was chopped liver. Oh my gosh. So the mother's voice, the mother's talking. So you have a huge impact on your child's comfort and your baby's comfort just with your discussions and talking. So I hope that's helpful. Answers? Okay, I got a little passionate there, so the rest of you are welcome to share as well.
I think that, I'm sorry, go ahead.
See, we're all passionate about this. We all want to talk at once.
Just very quickly, just to say, I think that recognizing, trying to get a feel for our family, that, when we're doing those first dressing changes with them, is really critical. Not every parent reacts the same way. Some just don't want to be in the room for the first dressing. Others are ready. So being really aware of where your family is critical to how you start. Kim is here with me today from Children's. We have a third nurse, Sue, who couldn't come. We also have a great new nurse practitioner. We always do newborn dressing changes in a pair, always two of us, and then we are just, our hearts might be pounding just as hard as mom or dad's, but we are always calm. And so trying to model a calm in an organized approach, like you've mentioned, making sure everything's cut, ready to go, having that partner, and then just going through it in a methodical way. And then exactly, I think we all had the same experience. it is always the most rewarding moment when the parent is like, yeah, no, you know, this is how I want it, and you're like, great. We encourage our families to be creative. Sometimes we'll say, does anybody in your family sew? Because if you take a dressing and think of it as a piece of cloth that you're going to make clothing out of, and you add darts and snips and curves, and you know, we have our sort of typical way of doing babies, and one family probably pretty quickly was like, oh, we're going to take this product and we made a pattern just like you would be making clothing, and we're doing it all in one piece, and it was pretty amazing. So being aware of where they are, being open to whatever level you're at, and supporting you till you get there. And it's on your own timetable when you get there. And then we also use child life therapists with our dressings or music, same things.
I agree as well with everyone. I think education is the key, and you have to slowly help parents get there. You know, we like to get hooked up with families right at birth to help start that education process. But I have to say my parents are the best EB nurses I've ever met, because they know, and I learned so much from them. So basically our job is to help them through that first process of feeling comfortable. And then once they do that, like I said, they're the best EB nurse, and they're my resource many times more than not.
And I think we use other parents, you know, as appropriate to be resources for other parents too, if that is, you know, what is needed. I think part of with infants, it's recognizing that this isn't what you planned for. And I think that's a big piece of it. And like Jean said, we go in pairs. There's usually 2 NICU nurses and a PCA to run for supplies. We call ahead, saying this is what we anticipate we're going to need. We want it, you know, cut this way. We want it lubricated already. Support the family if they are interested in looking on the internet. The internet is a great thing, and it's also a very scary thing with things that you can see and read. We have some parents that, you know, look every day and they're researching. We have others that never look. So I think it's really important to know your family that you're working with, know what resources they're going to have at home, and be able to support them in that way, using some of the child life techniques that Jean mentioned, and how is that going to translate into the home. Can they afford an iPad for distraction or some of these electronics, or can they not? Can you help them find other things? The parent knows the child the best, and trying to maximize their strengths at home is, you know, what we try to do. Even if that also means, as time goes on, that the parent needs to find somebody supportive that they can talk to about things.
Any other questions that come to mind at this point? Yes, ma'am. Okay, this young lady is asking, how do we feel about using Hibiclens? Any thoughts on using the Hibiclens cleanser?
We have a few families that, as probably everybody knows, if you speak to each other, what new families are trying sometimes becomes a question for you. Would this be a good thing for me? We consulted our infectious disease department at Cincinnati Children's to see what their thoughts were. They felt like it would be okay to try, but they don't want it in the water as a soak. They like on the washcloth and cleanse with a good rinse.
Sorry, just before you continue, I don't know what the cleanse is, so I don't know.
Thank you for pointing that out. Would someone like to explain Hibiclens?
Well, it's an antibacterial soap. It's a pink soap. In my personal experience with Hibiclens is I think Hibiclens works really well for gram-positive organisms, but if you continually use it, then you start having problems with gram-negative organisms. So we actually prefer bleach baths just because it's more broad spectrum. And the other thing, Hibiclens can be harmful on the eyes and ear canal, so you don't want to get that in your child's eye or ear. Plus, it can cause an irritant dermatitis if used too much. So, we, don't typically recommend that.
I would say our recommendations, like Jean had mentioned, it's for very individualized circumstances, and again, rinsing well afterwards because it can be very irritating.
Hibiclens is a chlorhexidine wash, and so I definitely use it at times, but it's more when the children are infected. I also take care of kids with atopic dermatitis and other skin conditions. And again, I will have them use it as a wash, and I'm on the same team as their infectious disease providers. So we do use it short term. Sir, in the back.
Yes, the patent for Hibiclens, Richard Edlick is a professor of surgery and is a fabulous plastic surgeon. Unfortunately, ended up with multiple sclerosis. He did the research on Hibiclens and so many other things. It was in the trauma community that I was in for a long while that Hibiclens was introduced, and that was where it was designed to be. So I don't know that it was designed to be in the setting of chronic dermatitis and certainly in DEB. So in all fairness, it's fabulous in the trauma community.
Yeah, thank you for that. Absolutely decreasing bacterial colonization. But for routine bathing, my experience again is just intermittent use. I saw someone's hand go up. Yes, ma'am?
Sorry, it was just around the same basis. I hear a lot, I walked in late, so I don't know if you've covered it. My children have dominant dystrophic EB, and we do a lot of saltwater baths. I hear a lot of bleach and vinegar. I understand that there is an infection. What's your thoughts on that?
I highly recommend the saltwater baths. It has changed our children's life and made cleansing a much easier process for them. And as a result, their wounds are healing better. They're having fewer bacterial complications because they can adequately cleanse their skin.
Well, we're getting really good results, and I don't want to say I'm going to switch because I'm getting good results, but I'm just incomparable, just curious kind of a thing. So,
Yeah,
I've never really used soap to clean their wounds at all. It's always been just saline water spritzed on it, or just in a saltwater bath and cleaning the rest of their body with soap.
and that's the pool salt, is it? Yeah, yeah.
Salt or ionized table salt.
Yeah. So yeah, we recommend it, and you can add that with the bleach as well. And I just use mild soap cleansers to gently cleanse their skin, like baby shampoo or Cetaphil cleanser. But we mentioned this earlier, we do recommend that you do try to cleanse off the drainage as well as the crusting that can occur. And Vaseline is a great way to help loosen up those crusts if they're adherent.
Now, you mentioned earlier bleach is anti-inflammatory.
Mm-hmm.
Okay, so that would probably be helpful to me. So can I use the salt and the bleach
Mm-hmm.
in the bath at the same time?
Mm-hmm.
So what we've covered so far is, securing some IVs and some bathing. And then we were going to go on and talk about diapering, but we have another question. Yes, ma'am.
I have a question. I have EVs, but I have two rare types, and I have problems with in between my bottoms, and I just got a curious question: how do people dress like the in between bottoms?
Okay.
I have a hard time doing that.
Okay. So her question is about how do you dress basically between your buttocks when you have two skin folds and you have blistering and skin breakdown in those areas. Thoughts?
There's a couple products we've used in hard-to-dress areas. One product is a no-sting barrier spray. 3M makes one, and Coloplast makes one. And it's, I've used it under the arms with good success. I could use it, the neck area is often a very difficult place to dress. There's a product that was designed for people that have a lot of obesity and they have a pannus that fold on their abdomen, which can get infected and have a lot of skin breakdown. It's a Coloplast product. Is that okay?
We're trying to not advertise for anyone. So if we'll use kind of generic names, there is moisture wicking fabric that's silver impregnated on the market, and I think that's what you're referring to.
Yeah. It comes 10 inches wide and 12 feet long, and you could use it in a variety of different ways, but it would work well for what you're describing. It's something that you might try. Yeah, there's a no-sting barrier type spray that it doesn't hurt to put it on, and sometimes it can protect the skin around an erosion, and it's just something that's sort of easy that can work well to help wounds.
When we were having coffee, we were talking about shoes. And who had those clever ideas about shoes? Was that you, Kim? Using larger shoes, and then we could move into dressings inside your shoes?
So for shoes, mostly for children, we have recommended something with the sole, something that opens wide, has a mobile tongue. Sometimes if you can purchase 2 different sizes based on whether you have a lot of bandages on or not a lot of bandages on. So those are kind of some flexibility. We've also recommended things that runners use for certain types of EB on their feet that glide on, that help prevent blisters. There's a fabric that runners also use called capilene that wicks away moisture. Sometimes they're hard to find in kids' sizes, but it might be for you. Those sorts of things we've used before.
And we also recommend shoes that tend to have wider toe boxes, and I don't know if I can make any recommendations, but there is a company called SureFit where you can find some shoes that are relatively inexpensive with wider toe boxes and then deeper heels. There's also a website, www.healthyfeetstore.com, you can look for some shoe options as well. But again, shoes need to be easy for them to slip in and out of. They need to support the foot, accommodate their bandages, but also be something that doesn't cause any injury. So usually those wider toe box type shoes are good. Mm-hmm.
So we go with a larger shoe. Some things I have done is used, silicone mesh, and impregnated that with petrolatum and slipped it between the digits, taken that piece and cut multiple strips and swirled each piece around the toes. I've tried multiple iterations, and the thin Vaseline gauze, wrapping each toe with like a 1-inch strip. So you go around the toe from the bottom, cross over the top, and then you just have it lay on the top of the foot, and do that 5 times. And then you wrap the whole foot with like a Vaseline gauze, is one thing I've done. And you've probably already done that. Did it work? It bunches up, and you got a hot mess. Okay, other recommendations?
We had one family, you know, it's learning from families. They took a thin silicone-based product, and they, if you had the square of the product, they cut slits, like if you were putting it on your hand, it would go over the hand. And then they darted, like almost like an arrow on each end, so that then as they slid it over, there was a little bit of a piece of it that came up on each side, but it flapped down over the top and the front, and they could just use a little roll gauze to hold it. And then you could put, if you needed a topical, you could put something. And they felt like that stayed secure, and they, this family does hands that way as well, so that the fingers aren't totally wrapped, so the child still has good tactile. So that was pretty creative and has been very effective for them.
The nice thing is those silicone foams that are thin and they conform well and they stay in place relatively well. Mhm.
Some of our families use that same thing, and they make like a shoe insert for the bottom of the foot, so not so much the toe, but the bottom.
Yes, ma'am.
With blisters, what is today, the best way you feel, at least painful, at least exciting, producing a liquid out of the blisters? When you, using a needle or something that will pull it out, or cutting it with a razor, what's really the most, best way to do it?
All right, next topic is blisters.
Well, what I like to do is I use a blade and I gently push the fluid to one side and then just nick the roof and drain out the fluid and leave the roof in place. You can do that. You can use a needle as well, but it should be, I think, a wider or a bigger needle so that you can drain the fluid out, because sometimes if you use too little of a needle, the hole closes up and it's hard to adequately drain the fluid out.
Yes, ma'am. Lancets, just like for diabetics.
They get them in different gauges, and a lot of times what happens is they have to be drained more than once, the blister itself. So what I find is if you get a smaller gauge, put a little hole in it, you can see how much you can get out, and then wait and see if it fills up again, and then use another lancet to do it. And a lot of times, after the second or third time, it might quit filling back up again. But the smaller the hole, for me, what I use actually causes it to kind of clog up, so that it doesn't open the leak of the blister back up. So a lot of times that'll end up staying intact.
Yeah, absolutely. We want to keep the roof of the blister intact as much as possible, because it then will act as a biological dressing. And we absolutely want to lance those blisters and drain them, as you know, so that it doesn't continue to separate the skin and become larger. So way in the back, I see someone with their hand up.
My name is John, and I'm 22 years old. This is actually about wound care.
Hey, John, thank you for coming, and thank you for giving us a question.
Yeah, thank you. And, like I said, I'm 22, and over the years I've had to learn how important it is to do the wound care, every day. And when I was younger, I would put it off because it was so painful. And one thing that actually I found, and I'm from Oregon, so we have the medical marijuana bill. And yeah, but, and I think it's actually, remarkably helped me out. And I think a lot of people are put off by it because you think you're smoking a doob, getting high, getting loopy, whatever. And they actually have one product that I found was the THC, or the cannabis oil that was mixed into a sucrose solution. And so it gave me all the benefits, like the pain relief and stuff like that. but I wasn't, loopy or anything. And so, I right now go up to our university hospital and go into the burn unit, and they have the big burn tubs that they put people in. And so I go up once a week and have a bath in that to get my wounds clean. And I think that, for one, has helped me out remarkably, just to see the wounds, to have my dermatologist come in to make sure nothing's wrong. But, it is remarkably painful. And, you're in a giant tub of water, and so you don't want to be all, spinny-headed and everything. And so this syrup, sucrose solution, has actually, it's really helped me. You just put a couple drops under your tongue, and it gives you all the pain relief, and if you want munchies, you can get the munchies. And what do you mean? Could be.
Hey, John, we couldn't hear what made everybody laugh in the corner. Can you tell us?
My mom was saying that was probably what Grandma's sugar water was.
Well, I can tell you that when I was a little girl, I grew up in a farm in Minnesota, and there would be these weeds in the yard. And my dad would tell me that was hemp, and that it was used for making ropes. And as I grew a little older, I learned that was marijuana. But it was actually a weed. Your granddad too. You had a hemp farm. But because of all the illegal issues and the using it for ropes, it went to plastic products, etc. That we have lots of discussions about hemp and marijuana and cannabis.
I know it's not legal in every state medically yet, but I know in Oregon they have little shops all over the place to go in, and they actually genetically engineer some of these. So if you're looking for a specific type, like if you just want to have pain relief, if you need to go to work, and still have some pain relief, you can take this type. Or you can, if you specifically need the munchies for some reason. Like I knew a friend who had throat cancer, and so when they operated, afterwards he didn't want to eat anything, so he was really losing weight, and so his wife ended up making some cookies and brownies, and he'd get a bite of that, and she said a half hour later she'd find them in the fridge.
John, thank you so much for sharing. I have a question. When you're going in and getting those tub baths in the burn unit, are those saline baths, or do they have bleach in those at all?
At first we were using bleach.
Okay.
And then my mom found this little company that has skin lotions and stuff, and there's this product I'm using now. It's I think a rock salt or sea salt that's mixed in with different types of oils and herbs.
Okay.
So it smells great, but it actually has, I'm not sure exactly what type of salt it is, but I know it has, different mineral salts and then oils and different things that help out the skin to get it exfoliated and moisture into them, and we also use a lot of the moisturizers from this company as well.
Okay.
And they really help to keep the good areas that aren't wrapped moisturized and don't break down from dry and itchiness, it actually really helps. And so I think we're still using the salt at this point, and I think it helped just as much, if not more, than the bleach did. So it really does help. So good news there.
And John, again, thank you for sharing. And this is one thing every single panelist. So every single panelist would say we are always learning from our patients. We're learning from our parents. And we know you guys have practical tips that you can always share with each other. And John, I think you're leading us right into getting those bandages on. And how we apply those. And I love that you pointed out the importance of keeping the intact skin healthy, using moisturizers and barrier products to keep that skin healthy before we do the dressing changes. So I'm going to go back to our panelists here and see what they have about dressing changes and applications and tips for taking care of kids and adults and babies.
Well, I'm sure we all probably teach the same thing to our parents, to use your first layer as the contact layer and to use something that's not going to stick when you take it off. And so there's a lot of different products out there. Some are more expensive than others. But I think about 20 years ago was the first time I met an EB patient, and that was before silicone dressings, and it sort of what they were doing was using Vaseline gauze with rolled gauze on top, and the Vaseline gauze always stuck. So it was a process of like soaking it off. So I think it's really important to use a contact layer that doesn't stick.
Any gauze, I think, sticks. Soaking them in different solutions, different creams, and everything.
Yeah. Yeah, and applying ointment to the bandages is important too.
Thank you so much. I just got that little message that we have time. But I would say any of you are so welcome to come on up and speak with any of us and ask any questions. And I know if you had questions on your mind that you did not have time to ask, those questions will be taken and they'll get those emailed to us, and those questions will be responded to. So thank you so much. I think we should give a special thank you to John. He's our 22-year expert.